Hello everyone, this is Dr. Ashok Gupta from Bansal Hospital, Bhopal. I am a practicing physician here with a special interest in diabetes and rheumatology. Today, I will be discussing a case study of a newly diagnosed type 2 diabetes patient with a high baseline HbA1c level. Mr. Anil Bajpayee, a 45-year-old male with newly diagnosed type 2 diabetes, visited the clinic 6 months back with multiple risk factors like obesity, hypertension, hyperlipidemia. He was initiated on metformin with advice for lifestyle and dietary modification. Recently, he visited again as a part of his routine checkup. His laboratory workup showed the following reports. HbA1c level was 8.5%, EGFR was 80 ml, LDL was 80 mg, HDL was 38 mg, and triglycerides were 200 mg. His current medications were metformin 1000 BID, lisinopril 40 once daily, metoprolol ER 100 once daily, atorvastatin 40 once daily, and aspirin 75 once daily. On physical examination, his BMI was 31 kg per square meter, BP was 120/70, and heart rate was 78 beats per minute. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complications in type 2 diabetes. UKPDS demonstrated a legacy effect of early intensive therapy because the difference in the CV event rate 10 years post-trial was apparent enough, though no difference in the HbA1c levels between the intensive and conventional therapy. When metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve the target more quickly, particularly if in patients with high baseline HbA1c level. Early combination therapy in type 2 diabetes makes clinical sense for several reasons. First, a meta-analysis demonstrated that the early use of combination therapy significantly increases the likelihood of achieving the glycemic target of HbA1c below 7% compared with the metformin monotherapy. For patients with HbA1c more than 1.5% above the goal at diagnosis, ADA and EASD guidelines, they recommend first-line treatment with dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients with established CVD, CHF, or CKD. EMPA and LINA combination with complementary mechanisms and pleiotropic benefits may be suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or high risk, established heart failure or CKD due to the intolerability of the combination, in addition to the potential benefits of empagliflozin on cardiovascular and renal outcomes. There is no increased risk of heart failure with either agent. According to the study, early achievement of HbA1c goal of less than 7% with EMPA-LINA combination could reach target HbA1c at 12 weeks compared to monotherapies. HbA1c decrements by EMPA-LINA combination of 25 plus 5 milligram has demonstrated 1.81% HbA1c reduction at HbA1c baseline of more than 8.5% at 24 weeks in the metformin treated groups. Benefits on glycemic control were maintained at week 52 in metformin treated groups, and a higher percentage of patients achieving HbA1c 7% were reported for combinations. The combination offers a suitable component in strategy to achieve target HbA1c without the increased risk of hypoglycemia and weight gain, with improvement in overall lipid profile. A reduction in the incidence of genital infections associated with SGLT2 inhibitor has been reported when an DPP4 inhibitor is added, perhaps because of better glucose control, although other possible mechanisms they remain to be investigated. So, to summarize, EMPA-LINA combination provides robust HbA1c reduction and 2 to 4 times higher odds of patient reaching the goal HbA1c compared to the individual agents with low hypoglycemic risk. Thank you.